What happens if you're not able to chew properly? You will not get everything out of the food in a way as if it would be possible. So what happens with your immune system? What happens with your general health?
Yeah, it really changes the way patients are treated.
What would you wish that you could measure in the future to make implant treatment closer, I would say, rated by general health topics?
And I think this is something we have to bring back to the people's minds, that the things that they are doing in dentistry, or let's say dental medicine, is medicine and not only dentistry.
Welcome to ProTalk. Welcome to the Paths of Dentistry. Welcome to this episode of our podcast series. Today, George and myself have the pleasure to welcome Professor Dr. Samir Abou-Ayash to Basel and to be guest in our podcast today. Welcome, Samir.
Thank you so much for the invitation. Great pleasure.
Thanks for coming over, and to our listeners today, you will learn how the young generation of academic leaders looks into dentistry. We will speak obviously a lot about digital dentistry and the future of digital dentistry. We speak about an aging population, and we speak about how Samir's work, academic work, has a very, very practical influence on your day-to-day practice out there. But first, to start with, Samir, who are you in 1 minute?
1 minute is hard.
That's why we do it.
Perfect. I would say I'm very much of a family person, so that is what comes to my mind first. So I love to live with my family, but I also love life. So I enjoy the beautiful things. I love eating, I love drinking, I love going out. So this is still my routine, like my balance to dentistry. But it's also when I go back in time, I think I was raised by my parents to be highly responsible. So I was quite different back in the days. My parents were both working, so I had to take responsibility from the beginning, and this goes through everything. So I took responsibility in sports. I'm a very competitive person, so this also stayed within me. And at the other side, I think I'm a very unpretentious person, and I think these are the main characteristics that describe myself best.
What was the sport that you are competitive in?
Was very much football.
Okay.
And responsibility. I was always the youngest, but I had to lead the team. So in my small village, I was very good. So I was not good in a high level, but in my small village. So I was the one who was always the go-to guy. Last minute, ball goes to me. And
you had to finish, basically.
I had to finish.
You had to score.
Most of the time, it didn't work out, but a different story.
Yeah, that's exactly. But that's also a good learning. Huh?
Exactly.
Samir, you grew very quickly in clinical practice and also in academia, and we come to this later. You have an impressive track record also of publications. What drew your attention to the academic world and the decision finally to continue your career in an academic, let's say, environment?
I wouldn't say that it was like a moment or an actual decision in one moment. It was kind of a process. So the process when I started at the university, when I got involved with research more and more, and then it came the time when I realized, okay, when you're at the university, you can really, really work on the future of something. So shape something that you are really looking for. So in the beginning, it was absolutely not my idea to stay in academia. So it was very clear for me, I will do my specialization training and then continue in a private practice. So I wanted to have a very high level of education. But then it went like in a direction when I realized what you can do with research, what impact research has on your surroundings. So when you have a finding and you can tell the people, don't do this, don't do that. And that's always the thing. What I'm saying is let's say, the greater good of being in academia. You can really educate people. You can recruit people to be a multiplicator of the things you are doing. And this is something you cannot do in private practice. And I think that was the time point when I decided to stay at the university, to stay in academia.
Mm-hmm. Yeah, it really changes the way patients are treated.
Exactly.
Because we learn, with each study, we learn something that hopefully is applied in private practice then later. But if you're saying it like this, do you have like a greater objective in your mind already?
When you ask me about a greater objective, I think this may have been the decisive moment. So when I realized what is the thing that I want to achieve with my work. So the way I'm seeing dentistry currently is I want to promote health for the people. And when I say health, it's general health. So in dentistry, we are focusing on the oral cavity, and we stay in the oral cavity with our ideas. So we do our treatments, restorative, implant treatments, whatever, and then we measure the effect, but we stay with the effect just in the oral cavity. Yeah. So, but the oral cavity, the mouth is the most important thing for life, I think, because we breathe, we eat, we chew. And the thing is, what happens if you're not able to breathe? You will die. What happens if you're not able to chew properly? You will not get everything out of the food in a way as if it would be possible. So what happens with your immune system? What happens with your general health? And I think this is something we have to bring back to the people's minds, that the things that they are doing in dentistry, or let's say dental medicine, is medicine and not only dentistry. And this is a decisive change that people have to make. And maybe also, when I'm in a group of general practitioners and I'm saying I'm a dentist, you always get the dentist. You always get this feeling, right? Yeah. So, but the decisive part that we have for general health is very much underestimated, and not only by general medicine, it's even underestimated by us. And I think that's the important thing, to put the light on this, and that we also understand how valuable our work is.
Mm-hmm. That's a very exciting and big theme, and it's great to put some data behind this. I think this is also probably what is missing today, sometimes the data to prove this, where we believe oral health has a big impact on general health. I have to ask you one question, because I know you've been studying and living in Freiburg. You've been working for and with Jörg Strupp. There you've been in Bern with Martin Schimmel and Danny Buser. With both of them you worked a lot, and now you are with Bilal and others in Mainz. So a lot of great people you surround yourself with, and you have been able to learn from. How have these different schools been different, and how did they influence the Samir that we see today?
All of them had a major impact on everything that I'm doing today. But first of all, I have to admit, you cannot be luckier than me having such an education. So when I started in Freiburg, there was this Strupp vibe. Yeah. So Professor Strupp was very clear. It's all about excellence, but you have to be excellent in everything. And only the ones working at the pros department are excellent. Yeah? So everybody else is doing shit. So we had to do everything by ourselves. Our, let's say, implant surgery, our perio surgery, our prosthetics, because we are the best in everything. So that was the attitude that was there. And that was something, this vibe, that was really lifted us to another level. When we went to a congress, it was the Freiburg team. We were walking around wow, we are Freiburg, come on. Yeah. So that was our attitude. But it was not, I have to admit, it was not only Strupp back in the days who was there. There were other great minds. There was Ralf Kohal, one of the pioneers in ceramics implants. And there was Petra Giertmühlen, another pioneer, especially in the field of lithium disilicate. So ceramic restorations. There was Wael At. Wael At, with his brilliant mind in the field of digital dentistry. And the thing in Freiburg was, what Strupp created was kind of an atmosphere, like a competitive atmosphere among his seniors.
Yeah.
And I said I'm a competitive person, but the thing is, I'm competitive when there's competition. Yeah, and when you're working basically in one team, there should not be that much competition. So I had the opportunity, and this is maybe one of my biggest strengths, that I was good with everyone. Yeah, so I worked with Ralf Kohal, with Petra Giertmühlen, with Weil Art. I still have a very good relation to all of them. And I had the opportunity to take everything of their knowledge out that I could get. And still, you felt that this atmosphere, this competition was maybe not the best atmosphere for like a common growth. For individual growth, amazing. For common growth as a clinics was kind of hard. And then I came to Bern, and it was the completely other way around. Okay. So there was Danny in surgery, and you would expect Danny, we know him, very strong attitude, but I was so impressed of his, let's say, of his mind, of his ideas, and how he behaved. You have to imagine you are there in the first week. You hear knocking on the door, Danny Buser, that you know from stage, like an idol, standing in front of you, and I heard you're the new guy. Can we plan an implant case? By the way, you won't do surgery here. I know you learned it in Freiburg. I show you the right way. So that was Danny's attitude. But what I found impressive was he was not calling saying, come down, I'm Danny Buser. We do an implant case. We plan together. He came up to me, sitting next to me, not knowing each other. And it was really impressive how grounded Danny behaved. And to be honest, when I first saw his seniors operating, I was like, okay, I thought I'm excellent because I learned surgery under Strupp. I saw Simone Jana operating and was like, oh, wow, okay, next level. So this is what changed my mind a lot. So my mind today is a little bit more like prosthodontist, focus on pros, surgeon, focus on surgery. So otherwise, when you focus on both fields, you will never get as good as somebody who's like focusing 100% just on pros. If you do both, impossible. You won't have enough time. And that was the mindset that came in Bern. And then was in pros department, was Bregger, amazing person. When I got to know him at the end of his career, very humble, and not this fancy type of research, was always about cost efficiency, no complications, and all this stuff. And I learned a lot from him. He always said when I wanted to do a clinical study, so he was always questioning, is this actually relevant, really, clinically, for a patient? Just do research that is relevant for the patient. It was a mindset. And then came Burak Yilmaz, great researcher. I learned from him to do structured research in a way I could have never imagined it. It was so hard to kick off my academic career. And with Burak, I had 20, 30 publications in 1 year, just relevant topics. And just because I learned from him how to collab and how to structure research in a way that it's efficient. So he helped me a lot to become what I am in the field of research. And then Martin Schimmel, cannot say, words are not enough to describe what he has done. Like, he completely changed my mind. Freiburg, focus, aesthetics. We are perfect in aesthetics. We can do everything nicely. And Martin, completely different way, was very much about oral function. So the thing that I was mentioning before, striving for the bigger good. So when we rehabilitate a patient, it may look nice, but what is like the benefit for the patient? Can he chew better? All this relation also in relation with the work with the elderly patients, where the general health gets more and more important. That was a mindset Martin really branded me, and was maybe the most influential person in my academic life. And now coming to Mainz. Mainz one of the big German universities. I was so impressed, negatively impressed of the pros department, not because of the department itself. I love the people there, but the atmosphere was like research hostile. The research, so the old boss didn't want to see research because he wanted to have patient treatment, because that's the thing what gives you money. And that was the focus. And now I have to change the mind in the department a little bit. But the base is there, so everybody can perfectly treat patients there. Now we have to implement research. We're doing that together with Bilal. And this interaction with Bilal is amazing. So we know each other for years. And he has a very similar way of thinking as I have. And I said before, the topic of general health is pretty much in my mind. So Mainz is now for the first time a real hospital. So we are working now in a real hospital surrounding with all the other fields around, but also like with maxillofacial patients. Those are the ones I think that can really, really benefit from our treatments. And now it feels as if I would be on the right place now to go the next step, working in the hospital.
Sounds like you bring a very, let's say, well-filled backpack to Mainz, at least.
I was lucky, as I said.
Yes.
Let's go a bit deeper on the publication topics, because you mentioned several very interesting points in terms of how you actually select what to publish, what to work on. And you already now have quite a long publication list at the young age. Obviously, it must have been something that really sparked your interest, not just to do research, but obviously to publish things that have an impact for patients. So how do you select your projects? How do you make sure that actually you stay true to this, let's say, aspiration that you want to do research not for the research purpose? And I mean, there is a lot of publications out there that just are not having a direct impact on patient.
Absolutely.
So maybe can you do some examples of also projects that you considered but then did not do because they did not have a clear impact on patients?
It's mostly those, there are so many in vitro studies with things you may consider in dentistry, but it's not actually a real question. These are questions coming by the industry. Like when new materials come on the market and you don't see the indication for the material at all, why should you investigate in that material just because of the industry that supports you with the materials and you can do the research with it? So I think time is too precious to do that. So when you do research for these things, it's just to increase the number of publications. But this may be the interest in the beginning because people need to get started. But the more you spend time with research, you have so many opportunities to do research. You have to select for the things you are really interested in. And when you're asking me how I select my research projects, it's very easy. So I'm working really, so my wife always complains why I'm still working on such a high level clinically. So high level in which means this high frequency, because she says when she sees other department chairs, they're not so working that closely with the patient, that often on the patient. So everything takes time. But the thing is, you're not losing the focus on the clinical reality. So most of my research ideas come from something went wrong. Mm-hmm. So something went wrong. The question is why? So what was the problem here? Did I do the mistake? Did I select the material that was not supposed to go there? So, or is it a material problem itself? Is it something how I treated the material? Things like that. Or also like when you have fractures, screw fractures, abutment fractures. You have to question these things, and these are the things where my questions come from. So patients come with complaints, or I have an actual problem with something that I did. So these are my basic ideas for research, and then the development of the bigger good. Questioning always, as I said, the next level. Like I named, for example, eating, biting, chewing. So we measure. With Martin Schimmel's help, we know now how to measure chewing efficiency, but we don't know how we measure the impact of a better chewing efficiency on our health. Mm-hmm. So now we need to collaborate with let's say, the neighboring fields of medicine. But if you don't have a publication record before, Yeah, and you come to them. They were, who's this guy who wants to do something now on health? What is this crazy dentist idea? They don't actually take you for full. And therefore, it's also important to develop first a publication record that the people see, he has done something in the field. Mm-hmm. And it's also for the acquisition of funding. You know, I cannot go as Samir Abou-Ayash 15 years before and apply for like a state-funded project of 10 million. It's like, I'm sure I get the answer within one day. So, okay, we won't consider further. So that's important. That's important.
Yeah, I really like how you actually choose your projects on impact. And I would wish that in academia, this is more often the case, because often there is also just the pressure to actually publish in order that you get enough, ranking, etc., that you can also apply for further positions. So I would wish that it's more considered like this.
But you know how it is. The thing is, I can do it now. So to get there,
it's not easy. Yeah,
it's crazy.
So
to get there, you have to publish, and then you're just they're reading application. He has published a lot. Maybe we can consider him for a position. Mm-hmm. So it's crazy for me that you first have to get into this position. You have so many young researchers that would be eager to maybe focus on more clinically relevant research, but to do it. They first have to get there that they can do it, and this is kind of a vicious circle.
It's that like a catch-22, basically.
We have to question why we only support or why researchers in high positions just get this high support, and not like junior researchers maybe that have a good support from their mentors.
But now you have it also in your hands, so it's I think. Now let's go a bit deeper into some of your work. Actually, the ITI Consensus Conference 2023, the 7th one, and you were in one of the groups that actually looked at patient benefits. So it comes back to your statement before. What was the basic finding out of this group? So what are patient benefits of implant treatments?
For me, it was the first time that the ITI actually really, in a consensus conference, tried to address patient benefits, not actually focusing on just the clinical outcome, but also on broader outcomes. The outcomes that we defined before the consensus conference was the patient-reported outcomes, how patients feel with removable or fixed complete dentures on implants. So patient-reported outcomes. Then it was about oral function. So if you rehabilitate patients with implants or not, what is the effect, or what has the bigger effect on oral function? Oral function like chewing, tongue pressure, lip pressure, all this stuff that is mainly measured in the Asian world, which is not so common here. And then also about the impact of implant treatment of keeping the own teeth. So if you have tooth loss in the back, so what happens to the remaining teeth if you put a denture that gives an unphysiological load on the remaining teeth, or you put an implant? Does this preserve the teeth more? So they ask questions that are a little bit abroad from the common things that we are measuring in implant dentistry. And the main outcome was chewing efficiency can be or is increased by implant treatment, at least in edentulous patients, which was pretty clear. What was interesting was a hard discussion that patients actually estimated removable overdentures similarly to fixed complete arch restoration on implants. So, and the interesting thing is we had severe discussions on that, because there are people, consensus conferences, who created their business model on it. They're like, we're just doing all on 4, all on 6, but
needs to be fixed.
They don't want to hear something like, hey, patients like overdentures on the same level as fixed restorations, at least when it comes to the results of patient-reported outcome measures that we are currently using. So you can ask now 2 questions. So is the patient-reported
age dependent? So which age cohort are you taking, and are you asking?
This is what we always thought, but in the end, it's not age cohort dependent. It is age cohort dependent, but you're not. The thing is, the edentulous patients nowadays are rather old. So you have the cohort from the beginning. When you focus on edentulous patients, you normally focus on elderly patients. But the thing is, the question that we have to ask, is it really like that? That it is found by the patients to be a similar treatment, or do we just not ask the right questions to the patients? I have a little bit my problem. The most common patient-reported outcome measure that we're using is the OHIP questionnaire, focusing on oral health-related quality of life, and there's not a single question on implant treatment in there. And nowadays, it's not only important what the outcome of a treatment is, that we have a shift in mind of the patient. Also, the actual journey there is very important. How the patient in the end evaluate the treatment. So nowadays, it's not only about the patient-reported outcome, it's also about the patient-reported experience. And this is something that has to get more clearly in our minds and also in the minds of the general dentist population, that this matters. And actually, we even have praxis concepts that focus on the experience of the patient, because we realize it's getting more and more important. I fully agree.
It's so important. And there's a nice link to what you said before in terms of your goal in general health. So what would you wish that you could measure in the future to make implant treatment closer, I would say, rated by general health topics? Because right now it seems to be very much linked to, I get an implant treatment and I look at oral health, but general health is maybe less considered. So what are your wishes for future measurements that go beyond that?
You have to see. I think it stands and falls with what the consequence of implant treatment is. For me, it's clear. The food uptake may change. We know that especially elderly patients need consulting for that. So even if they have better chewing or potentially better chewing efficiency, they will not change their behavior. So, but when they change their behavior, we have to measure this impact on. We can do this, for example, by blood values, but we can also do that by the body composition. When you have bad nutrition, you will have more fat mass. And you will see when you measure it that you have a transition from fat to muscle mass, but we are not measuring it in general. We're doing this maybe in 1 of a million studies. But the outcome is so interesting and it's actually easy to measure. But the thing is, we need this link.
It requires a much broader, I would say, holistic view on the patient and collaboration between different specialities.
And the thing is, dentistry or dental medicine, we were very good in keeping all other people out. So we wanted to keep all other people out. We didn't want anybody to tell us what to do, and we were happy with it. But I think it has to change a little bit.
I would like to focus a bit on elderly patients, as you mentioned, let's say 65 years of age and plus. So how do you see these age group covered in today, let's say, implant dentistry focus and, what we developed over the last years? Do you think they get enough attention, or do you think that's something that is underdeveloped? So how do you look at this group?
I think they are not sufficiently covered, especially in research. But when we look, it's very interesting. When we look, there is something Danny has done brilliantly in Bern. He published trends in implant dentistry in Bern and focused on different criteria. So, and then when you see the newest evaluation for the last time period, you see that every second patient who receives implant is older than 65 years. Every second patient. And so that brings me back to my beginning. And I remember it was the discussion back then, if a patient older than 65 years should get implants. So it's just 15 years ago. And when you look at that, we see the development, but we also see some uncertainty. And I think what we have to make clear is that implants in elderly patients, 65 plus, 75 plus, they work so well. You see that it was a rumor that they wouldn't work as well as in younger patients, but maybe it's even the contrary. We see implants in those patients when you go to a nursing home, something like that, caries all around, and then you see one implant. Implant covered with calculus, with plaque, and you have to scratch it away and you see, oh, there's an implant below. Very interesting. Everything is bleeding. And you think, okay, maybe I can take the implant just out because it was covered so long by calculus. And And you take, and then you make the patient come to the practice. You take an X-ray, and you see
It's fully
a perfectly stable bone.
Yeah.
So, and the thing is, this is something that we also found in elderly patients. We have more plaque, more bleeding on probing, but we have less periimplantitis. So, and you think plaque and so on, oral hygiene is a major factor for the development of periimplantitis. And I think so too. But the thing is, we know that something happens as the patient ages, the immune system ages. So we have not fully understand this effect yet. But this is the thing that I'm saying we need to collaborate with the other fields to understand that. Because it is really something that we see, that the implants, the intraoral condition looks worse in elderly patients, but actually the impact on the bone stability, the occurrence of periimplantitis, we have mucositis, we have bleeding, but we have no effect on the bone. And we have to understand it, because maybe it's not only a finding, maybe this could also be a therapeutical thing that we can follow. If we understand it, why it is like that, maybe we can modulate the immune system in a way that it's also working in younger patients. I don't know. But first we have to understand it. So big dreams for the future.
No, but a very interesting observation. And going back, I mean, the Swiss cohort that you mentioned in Bern, every second patient is an elderly patient, 65 plus. I think listening to Danny, it's also a lot of single-tooth patients there, right? Which is probably based on a very specific way. In Switzerland, people since a long time are educated on hygiene, oral hygiene. But let's look into, let's say, full arch treatments, specific implant bone removal, overdenture patients, because I saw you did some work on this, and it's a field that is interesting me a lot. And my feeling is a bit, I'm in this industry since 20 years plus, not a lot has happened in, advancing treatments of removal overdenture patients.
Yeah.
It didn't receive a lot of attention in research and also in innovation product development as well, we have to admit. How do you look at this field, removal overdenture, and what is it that we should fundamentally do different there?
So I think the future for overdentures is actually very bright, because the thing is, what we have to see, first of all, it's not only that we place implants in elderly patients. We have patients that are growing older with their implants. So we will come at the point to the patients, maybe when they are edentulous, but they have already some implants. So then the question will be, where is the implant position within the jaw? Can we go fixed at all, or should we just do a removable overdenture? So I think we will have the patient population coming from there. We will have a patient population that is wearing fixed full arch prosthesis already, that maybe transition to implant overdentures. And I think what the Consensus conference showed us brilliantly, that the patient-reported outcomes as well as the oral function is so much superior with implant-supported or implant-retained overdentures compared to complete dentures, that I believe in the future that we will not see the general complete denture, the removable complete denture, the standard denture, we will not see anymore. I think we will have a transition from standard complete denture to implant overdentures, because the price for an implant overdenture will also decrease. So we'll need the implants for sure. But the thing is, with all the new materials that we have, with the digital designing processes, the digital manufacturing processes, the costs for an overdenture, maybe even without a framework, we can mill it monolithically from PMMA, highly polymerized from a POC. We can mill it from zirconia. We can even maybe in the future print it yes. If the material properties are well. Yeah. So the costs are not higher than for a complete denture. The only costs that the patient has to cover is the implants and the surgery, which may be, and this is also something which may need a shift of mind, maybe will be covered by health insurances in the future. Because when we have so many benefits, the health insurance should cover that. When the treatment costs are not higher, And maybe we have the health insurance covering it, but we have to say, I don't know if the health insurances want that the patient live longer, because then it's getting expensive for them.
Let's hope and assume yes, but again, it's going back to what you said. It's impact of this implant treatment on general health.
Yeah.
And it's interesting what you do, and I think I want to underline this: you're not comparing a removal overdenture treatment to is it better or worse than, let's say, a fixed full arch treatment?
No.
But you compare it to a general overdenture treatment, which clearly, is not a great
is inferior
place to be for a patient. Yeah. Right?
Exactly, and let's frame it a little bit differently. So you have the patients developing, the evolution in the patient. So a patient who is wearing a fixed complete denture on implants in the beginning, maybe at some point, for cleaning issues, it may be easier for them to clean an overdenture. So we transform the restoration, and with the digital tools, we can easily do that because we had to do a design for the fixed restoration already. Maybe we can just copy design that we had before, put a denture base below, giving it a denture design, and then use the same tooth setup, same tooth position, the same jaw relation, which will also make the adaptation for the patients much easier. And we know that this is an issue, especially in elderly patients. So when this transition comes from fixed to removable, thanks to the digital tools that we have nowadays, we can even ease the adaptation for them. So, and I think when we can ease the adaptation, it might not be that big of a step also for the clinician to switch from a fixed concept to removable. So therefore, I think that when this mindset is coming to the people's minds, I think that we will clearly see the indication for overdentures rising.
Yes.
Perfect segue to digital. So let's talk a bit about digital dentistry. And I know you work very digital. You're very much interested in new technologies in digital dentistry. Let me start by asking, is there one digital technology that stands out for you that really not only changed your workflow on, let's say, small bits and pieces, but changed your way how you think and how you treat patients completely?
For me, clearly, intraoral scanner was
Game
amazing.
changer.
This was so much a game changer when you think where it was coming from. It was in the mid-80s. Yeah, when we see the two directions like Duret in France and Mermann here in Zurich, yeah, with the idea of intraoral scanning in a time when I think back to my Commodore 64, and they were thinking of an intraoral scanner. It's amazing. This was science fiction. And nowadays I cannot think of a world without intraoral scanners. So we are doing nearly everything with intraoral scanners. And it's not only a benefit for me as a clinician, it's a benefit for the patient. So did you know that there's a study looking in why do patients hate the dentist?
Going to the dentist?
The fear, two things. The biggest fear is the injection. The second one is the impression.
Wow.
Yeah. The second one is the impression.
Yeah. So it's very uncomfortable.
It's very uncomfortable. And I think we all know this, all the material going back there, we hate it. And the intraoral scanner has become a real game changer. And now I think it's evolving even across the fields of dentistry. So when we look, I have a senior in my team who is very strong in forensics. Now, when we look into forensics, it's crazy. You know, per Interpol standard, you have Moni, yeah, right. You have 3 ways to identify a person: DNA, fingerprint, dental status. So these are the only things that are allowed to identify a person 100%. So the thing is, the intraoral scanner can give us so much information here. And something that I learned from her is we have a unique intraoral fingerprint, the papillae. The papillae are as individual as the fingerprint. And we're collecting these data in every treatment now. So for forensics, intraoral scanners are getting more and more important. So there are even like police departments asking us which intraoral scanner we should buy. So it's crossing borders. And you see, so intraoral scanners have really changed a lot.
So for some people, this might not be the biggest motivation now to get intraorally scanned. But
true that.
No, that's interesting.
But there's data protection still.
There's data protection, exactly. You published already quite early on about workflow innovation. So what we call workflow innovation is basically how do you connect digital tools, digital workflows with also hardware that you modify. And in this case, I think it was published 2019. It was about combining healing abutments with intraoral scanning capabilities. What prompted you to be interested in this? In, let's say, this part of innovation, and did it really change the game as you expected it?
Not yet, I have to admit, but I think it will. The thing is, what I never understood. So when the patient came to me and I had to take my impression, independent of if it was like digital intraoral scanning or conventional implant impression, you have to dismount the healing abutment and then you screw your impression post, whatever in, you're compressing the soft tissues, you're trying somehow, maybe you had a provisional, you're trying to somehow copy the emergence profile. There's so many techniques out there, how to copy the emergence profile. And when I read those techniques, I'm thinking, okay,
it's very
this
analog.
is no idea. No, it's either analog or it takes me an hour. Mm-hmm. So I think digital tools should ease our life, so make our workflows efficient. And the idea of having a scannable healing abutment that is already conditioning the soft tissues in a way that I want them to be, and I don't have the need to disrupt the connection between the soft tissues and the healing abutment by taking something out, putting something in, taking something out, putting something in. Amazing. And we now in Mainz we have created a workflow after surgery. The surgeons do the intraoral scanning of the healing abutment, send the patient home, send me the files. We do the design, and the first time that I see the patient is really when they're coming to insert the crown. Mm-hmm. So it's like I'm like a magician for them. So I come in, I have a crown for you, beautiful. We put, it fits,
and it perfectly fits.
No
how did
pain.
you do that?
Exactly. So
excellent.
Bilal is taking the pain, and you are the hero.
That's what I love. That. I love this work share.
So you spoke about the impression the intraoral scanners left on you. But still, Samir, we have to admit, penetration of digital tools in dentistry goes very slow. And, at the end, if we speak about workflow innovations, be it for removal of a single tooth patients, you can only benefit from future innovations if you have an intraoral scanner. Otherwise you're just locked out of innovation for the future. From your perspective now, talking to the teacher in you, what is it that all involved parties have to do to really, let's say, accelerate the adoption of intraoral scanners and digital tools in dentistry?
That's a good question. The question is if we really want to accelerate. And I'm saying that because of a very important thing. Whenever I see there are so many brilliant inventions in the field of digital dentistry, but in the end, it's sometimes hard to get them in the process chain. So a workflow that works nicely for a very small part can be very frustrating when it is not connected to like a perfect treatment chain. So like after this step, you do this digital step. When you have to go back in the real world, it is not the thing that you want to have. And I see this when things are thrown on the market very fast. They have nicely thought about one problem, but not the problem or the next step that comes after solving this problem. This is very frustrating for the people because they buy, let's say, an expensive tool, and then they just solve a mini step in the treatment. So, and therefore, I'm saying, I don't know if we want to accelerate it. I would love when we have more digital tools on the market, the penetration through the market would be bigger, would be amazing. But the thing is, it is very important to be very thoughtful how you launch your products in the markets, to make sure that you don't have this frustrational moment for the practitioners. Because when you have this frustrational moment, it will take more time for the practitioner to do again a step in that direction. So maybe by throwing things too early on the market, we even decelerate this process, because the people are aware that something may go wrong. Things that we don't have asked yet is, even if we come with brilliant ideas, with complete workflows, is the infrastructure already there that we can apply all these beautiful things that are very well thought of by the industry? So sometimes it's not even, let's say, the prices that hold the people back, or the integration in the complete workflow. Sometimes it's just the infrastructure, the speed of the Wi-Fi. Let's say the cloud servers.
Yeah, exactly.
Now the cloud servers that are somewhere in the world, some people are very concerned about that. Yeah, they don't know where the data are. So there are companies that are really going on a cloud-based workflow only. And the idea, I think it has to come like that. I think that we will see this shift. But the thing is, I understand people that are a little bit reluctant to these things because they are questioning, okay, where are those data? I don't see those data. And this is something where we have to convince the people, to tell the people, to give them security. And I think this is very important when we really want to accelerate the penetration of digital tools in our field.
I think that's a fair objection. You know that we created a lot of digital islands, and then, people have to jump islands, but in between they have to go analog again, which is very cumbersome. And I think this is where all this, ecosystem and platform developments go to create an infrastructure that, you have a digital tool and then you stay digital. And you continue,
exactly.
As I said, the treatment chain, the treatment chains continues digital and goes digital from one step to the other in a flawless way. And I agree there's a way to go, but I think the platforms developed like Straumann Access and others, I think that this is the step that was much needed.
And we need that without the industry, without giving us the opportunity to go those ways. Nothing will move forward. So I love it that you guys doing it on a great level. Thank you for that. But I see the point for some of the practitioners to why the adaptation is not as fast as I think we all wish it to be.
It takes a lot. I mean, just this compartmentalized data, it's just not so impactful. So if you have your data locally on your machine and you can't share it with your lab, or let's say with the next step, so it actually, I think it takes much more than initially thought to connect those islands. And maybe it doesn't meet the eye immediately how much is needed in the background to make those connections actually work reliably.
I think these are things you are thinking about. These are things we are thinking about. Yeah, but I think we all have imagined in the beginning it's much easier. Yeah, it's much easier, right?
And you compare it also to consumer, let's say, data handling that is already at a very high level.
Yeah, but we see already some technologies, in our hands on the mobiles is already available for us since 10 years plus. Some of the things we just now have to transfer to also, implant dentistry, like, cloud-based systems that, we haven't had for a long time. And I think it's about time. And it also, it's not having it, it's also limiting for us a lot in the innovation space. Samir, I know you also, from being very engaged in associations, like in the German Association for Implant Dentistry, in the ITI and in the German Association for Implant Dentistry, you've been, let's say, representing the young generation for quite a while. And so you're active in this space of associations and foundations. What is it that, from your perspective, these associations have to do differently in the future and bring to the table to really help the young generation to do the next steps? How do you look at this?
That's an interesting topic because some of the institutions, some of the let's say the faculties and so on, they are pretending the young generation, they are difficult. They don't want to engage. So the thing is, they want to engage, but maybe the people are not understanding that they want to engage. You know, when you want people to engage, you have to give the people some trust, to give the people also space to engage. So some of the, let's say, the German Association of Implantology, the ITI and so on, they have understood that they have to create paths, to create ways, and to also include young role models that go the way, like starting as a young fellow, whatever, and moving up in the hierarchy. But there are also, like, now let's say, the German Association of Prosthodontics, which is, I have to admit, kind of a retirements club, or they behave like a retirements club. There are so many people, there are so many brilliant minds. They have all deserved to be there because they have done so much for prosthodontics, but they don't leave enough space for the people to engage. So maybe because of fear, maybe because they do not understand the ambitions of the young people that come with disruptive ideas. Now, like when you show them like a TikTok style videos, YouTube shorts, whatever, you show that to them, what is that? What is this? But this is how education has to be nowadays. If you don't do that, and I think this is a task that some major companies, some major educational sites have understood. If you don't take this up, you leave the space for rubbish social media education, where you can see things like me. I'm sitting there. How did that work? This cannot work. This can work. I don't know. So, and if I'm asking that myself,
then you go deeper.
So yeah, that's it. But if I'm asking that myself, a young clinician sees that and says, "Oh, that's cool. I'm going to do that in my practice on Monday." Yeah, that's cool.
Good idea.
Cool. So, but that's not the way of education that we want to have. So we have to take up the responsibility to see what the young generation wants and to implement that in our current approaches. Otherwise, others will do, and I don't know if we like the result.
So on the flip side, so basically on the receiving end, what would you recommend to young clinicians how to actually deal with those associations?
The thing is, what I have always seen, when young people really wanted to engage or to get engaged, they got engaged. So when they went to the institutions saying like, "Hey, I have a concept for a young clinician program, or maybe a young study club series," the people are happy that the people in the leadership positions are happy that the young people are coming to them. Maybe they do not understand it, but when they're coming with a concept, they try to pick it up. But what is unluckily not happening, especially when we have institutions that have, let's say, a certain age level, they don't come out to the idea to ask the young people themselves. So I think that is weakness, that the people cannot ask the young people themselves, that the young people have to come. But if you want me to give an advice to the young people, I'm saying don't wait for the older people to come to you. Go there.
Proactively go there.
Productively go there. And don't be the elephant who is destroying everything. Just go there and be polite. And the tone is still very important, especially when dealing with the retirements club.
That has accumulated a lot of expertise and knowledge through many years, right? And it's worth tapping into this. Samir, there's also a habit that we have a question from the audience for you, which is actually a quite interesting one. The question is, do you have a non-dental routine that secretly makes you a better dentist?
I think it's my life beyond dentistry. So actually that I have a life beyond dentistry. So when I go home, no, it truly is.
Yeah.
When I go home with my family, so I can skip dentistry out of my mind completely. So when I'm with my friends, we even can talk about non-dental topics. Can you imagine? So I think there are people. You see? No, the thing is, there are so many people in dentistry that are just focusing on dentistry, and everything is dentistry, and dentistry is very important for me. Yeah, but still, I think you need to have a life beyond dentistry to become a better dentist, to understand the needs of people who are not in your field. And if you ask me about my, let's say, secret, this is it. To have a focus that is pretty much out of dentistry.
Yeah, it's something to do with balance, right? And
exactly.
Yeah. Sometimes, the distance to your topic brings the best ideas at the end anyway, right?
So this is the thing, when the best ideas always come to me when I'm running and listening to music. So when I'm completely away and then there's something in the music now, oh, wow.
Samir, I know you also brought a question to us that you always wanted to ask.
Yeah, it's, I told you before, I'm really focusing on, or trying to focus on, the bigger good in dentistry. So you're here in Basel, let's say in the Napa Valley of the pharmaceutical industry. So what are your approaches, like not only with the pharmaceutical industry, but maybe also to cross the border in the industrial field to make dentistry more dental medicine again?
I really like the question, Samir. It's something that also keeps me quite awake, because I strongly believe as well in the power of, let's say, oral health in the realm of general health. So it has a much bigger impact than just the general or the oral health if we do implant dentistry. And the question is, of course, how can we be part of this, and how can it become one of our strategic pillars to as you have also strived for, be there for the greater good of the patients. Because one thing is to restore a missing tooth. It's great, and I think it has an impact, and we know what it does. But then the questions that we touched on before, what's the comparison to doing no treatment, and why is implant treatment a good option and a better option than doing nothing? I think this is something that for us is really important. Now, to put this in a broader perspective, our medical devices, they are also in a very special place in the body, which the prosthesis, the implants, all these medical devices, they have contact with blood, they have contact with tissues, they have contact with saliva. They are still quite accessible in contrast to many other medical devices, like exchange a battery on a knee. There are knee prostheses, they have batteries in there, but they run out after 1.5 years. So in the prosthesis, if miniaturization goes further, improves further, we believe that we can make smart devices which actually allow us to measure continuously health-related parameters that go beyond just oral health. Yeah. And I think this is something that drives us a lot. I mean, it's not directly related to pharmaceuticals, but then you can think about how these data can actually help to further personalize treatment that go beyond, again, the oral treatment with implants. So, for example, if you can monitor food intake, if you can monitor specific parameters of disease, and you could actually give indicative directions on how to, for example, administer a drug. So, does it need to be more or less? Is it saturated, or do you need to actually decrease the intake? These are all things that today we feel that medicine is still kind of early stage, non-personalized, and potentially with these medical devices we can further increase the personalized treatment options.
Amazing.
Yeah, and I think beyond the impact that you had on food intake and then the link to general health, I believe there's a big impact on psychological well-being as well. It's hard to measure, but there are means to measure. But if I see what you guys are doing to the patients and how life-changing this is, very often I'm pretty sure there's a very strong link to general health as well. But we can't measure this with
mental health.
Mental health is a big topic, yes. So this brings us to the end, George, of very exciting 55 minutes. How to summarize? What are your 3 key takeaways, George?
Yeah, first of all, thanks a lot, Samir. It has been a great conversation and a lot of also personal remarks. So it shows, this duality of a very, I would say, successful professional person, but also grounded in your, I would say, non-dental life. And to me, let's say that the highlights or the common themes, it's like a red thread through everything that we had discussed now in the last hour. So first of all, I felt that you really want to create an impact for the patient. And we discussed about the selection of your publication areas, of your scientific work, etc. All you want to create impact for the patient. And to bring this to the next level, you're not only thinking about dental health, but you're thinking about general health. And that brings us to the third level, which is basically your desire to connect better the different medical fields, because we can't solve it on our own. So dentistry alone is a bit, as you discussed it, also isolated, and your, I would say, aspiration is to bring it closer to general health, general medicine. And I think this is it's a very nice thread that stood out for me prominently.
Very nice wrap up.
Yes,
thank you.
So thanks for being here, Samir. I have to congratulate you. I really observe you being someone also that would like to push out the frontier of dentistry and implant dentistry further to let's say a bigger connection to general health, which I think is a beautiful objective that you have, and I'm sure we're going to hear and read about your research work in the future. So thanks for being here.
Thank you.
So this was it with Samir today, and I hope you enjoyed this episode. If you liked it, if it provoked some thoughts and changed your mind and made you think, then please share it and recommend it to your colleagues as well. And other than that, we always appreciate if you connect to us on the usual podcast players and on Instagram. We're always happy to receive a note and to respond to it. And thanks a lot for being with us and looking out for the next episode. Thanks a lot.